Our next speaker is Dr. Alex Kahana. And I want to begin with a quote. This is from William Osler, and you've heard me quote him before. He says, "The desire to take medicine is perhaps the greatest feature which distinguishes man from animals." We physicians love to prescribe things. We love to prescribe medications, surgery. Oh, it'll make you feel better. You've heard about the placebo effect. Before we prescribe, we need to understand what causes pain, what is pain, what is the suffering to the patient. And Dr. Kahana is a world expert in this topic. Let me give you a bit of his background. He's a professor here at the University of Washington in anesthesiology. He's chief of the Division of Pain Medicine, and he's director of the Center for Pain Relief at the UW, and this is at Roosevelt Clinic. He actually tells me that we have the distinguished honor here in Seattle of having the first pain clinic in the world. This is his stated goal. He's working to minimize patient suffering. He also wants to broaden physicians' awareness of pain and to teach us all how to better treat it. He obtained his medical degree from Tel Aviv in Israel. His residency was also completed in Israel. He then went on to a fellowship in pain management at Vanderbilt. Also, he obtained his master's and ultimately his PhD in bioethics and medical humanities in Switzerland. And I put here the title of his thesis. It's a great title. Why does pain hurt? That is a great question. He's the expert in it. He has a very long curriculum vitae. He's involved locally, regionally, nationally. He is chair of the research committee for the American Academy of Pain Medicine. He's actually leading the creation of a national pain registry here in the US. And in Washington State, he's developing the Washington State Opioid Reform Initiative. On top of this, he speaks 6 languages and we are very lucky that we have him here in Seattle. As a clinician practicing, seeing patients with chronic pain and acute pain, it's a very large part of what I do on a daily basis, and we often rely on individuals to give us advice. So thank you, and I would welcome Dr. Kahana.
Turn this on. Indeed, we have a large footprint, and you can see here the 9 pain programs within the University of Washington medicine system, at the Medical Center at UW, at Harborview, at Children's, at the VA system, and at the Seattle Cancer Care Alliance. So it's really looking over, either by inpatient or by outpatient, all the different types of pain and all the different types of complaints. Now, the last 50 years were phenomenal in terms of the technology that we've all been enthusiastic about in medicine. And you know, we can take antibiotics, for example, or organ transplants. And we can look even at imaging, the transparent uterus and the transparent brain. But when we look at what's been going on in pain medicine, there has been relatively little progress. If you read the first edition of the pain textbook in 1959, you'll see pain is an undertreated disease. And then when we look now at our 4th edition that just came out, you'll still see that pain is an undertreated disease. So what is going on? Why are we so successful in other fields in medicine and have this sense of some stagnation despite the billions of dollars that have been invested in patient care and in research? So first of all, pain is hard for us. And when I mean us, I mean healthcare providers. We're actually not taught to treat pain in school residency, and we are now working at the University of Washington in really putting an overarching curriculum in all the years and systematically putting this in, and to know that pain is something that we have to deal with, and explain perhaps what is the difference between pain as a byproduct of a disease and pain as a disease within its own. There are no tests for pain. There's no painometer or dynamometer. And that there are also, I would say, political problems that are going on. Damn if you give too much, damn if you give too little of medications. There are doctors who are being arrested for what we call pill mills or prescribing too many pain medicines. And there are some patients that are selling their medications. So this is a very, very strange environment to be in. And this is not new, by the way. Voltaire used to say that doctors pour drugs of which they know little for diseases of which they know less into patients of which they know nothing of. Now, pain obviously is hard for the patient. And you can see here the screen by Edvard Munch, and you can see that, again, there are no tests for pain, and the patients do feel isolated. And even with the most strongest support system, there is no one in the world that can understand my pain, that can understand what is I'm going through. And this sense of isolation obviously causes sadness, and we become worried and become angry, and even a mixture of all these feelings, which we like to embellish and call depression and anxiety and so forth. But this alienates us. It changes the trajectory of our life project, and we change, and we're not the same people we've used to be. And because the tests are negative, and we'll talk a little bit about that, what does that mean when the doctor says it's all in my head? When the tests are negative, doctors and also employers or even family members kind of saying, this is very strange. Obviously, pain is hard for society. The costs are enormous. It says here, good news, according to the government, you're not dead and you can go back to work. So there is a lot of disability. There's something that's called absenteeism, but also presenteeism. To be present at work, but not to be productive, because I'm all the time thinking about my pain. And this suffering tears apart the family fabric. Now, why is all this? What is so special about pain? Well, the problem essentially is that the patient can complain of pain without having pain. And this is called the problem of the other mind. How do I know what you mean? So when I say I have a pain of 3, 0, no pain, 10, the worst pain imaginable, so I assume that the scale is the same, and I assume that your 3 is also my 3. And I put it on a linear scale, although it's a nonlinear phenomenon, because we don't have pain 1, 2, 3, but more 1, 2, 3, 7, 8, 9, 10. And also the patient can have pain without complaining. And that's what's called the contingency problem. That is, for example, every object that has 3 sides is a triangle, and every triangle has 3 sides. That is not the same with pain. And so when we look, this group of individuals that you're seeing here, do they have pain? Are they pretending to have pain? Are they looking at someone of you, perhaps, that is having pain right now? Very, very difficult to decipher. And this is written here, I'm the one with the medical degree, so I'll determine if your back is bothering you or not. And the idea is that there is an inherent discrepancy, an inherent gap between the first person report and the third person report. And patients invariably always say that, doctor, please believe me. Please believe me. And so how do we objectify the subjective? How do we bring value through the scientific methods into something that is so private and so personal? So what I'll do is, very quickly, I'll go over 5 truisms, and you'll have to believe me on that. I will talk about pain out of the head. I will talk about pain in the head. And I will caution you a bit about all the wonders of technology and tell you about a short word about suffering. And at the end, we'll talk about the future at the University of Washington. So when you look at this picture, I assume that we're all seeing the same thing. We're all seeing the same thing. I'm seeing 9 dolphins. Here's a dolphin. 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 And if you haven't seen a dolphin, shame on you. So there's a gestalt. There's a way we look at things. We assume. We take inference. So obviously, all the people, all of you will respond to pain the way I think you should respond to pain. Now, with what organ do we feel pain? What's the organ of pain? The brain. As we do not see with our eyes, but we see with our brain. As we do not hear with our ears, but hear with our brain. We do not feel with our body. We feel with our brain. And it's not about psychology. It's not about the memory of pain and the pain of memory. But as you see here, this is a patient that I had, a young gentleman. And as you see here, he has one arm here, and here he's amputated. And he came to me and said, Dr. Kahana, I feel that the fingernail is piercing the palm of my hand. Okay, because when he lost his hand, he was holding a screwdriver. And 4 months later, it makes sense. The fingernail grew and pierced the palm of his hand, and that hurt. So, do we give medication, injections, surgery? What do? And so we created this box with a mirror in between. And you can see here the box, and you can see the mirror. And he put his hand here, and the stump is here, and we asked him to look at the reflection of his hand. And as he was doing this and looking at it, he was opening the hand, and we pulled the nail out. So that means that the brain does not need a body to feel pain. Brain doesn't need a body. You take my brain, you put it on the table, connect the mouth, it will complain. There is no need for body. Unfortunately, there is a true confusion between pain as a byproduct of a disease. Take care of the disease, the pain goes away, and pain as the disease. And so an indirect answer to the question, are people more vulnerable? Then the answer is absolutely yes. There are people that are more vulnerable to develop pain as a disease. The combination of genetic factors, the combination of some personality, life events, expectations, all blend together and create who we are, and obviously our individual response to pain. Now, we all understand that pain is a very complex response, and nobody really thinks that pain, and I'll show you some slides, is just what we call the nociceptive input, that input that comes from the pain receptors, the nociceptors. But that there's a whole experience, and that experience is contextual, and we talked about the beliefs and expectations and placebo. But there's also the personality or the cognitive set of where we are, and also the mood, and obviously the chemicals and structures of our brain. And so we are misinformed all the time. We are misinformed by our doctors about pain. We are misinformed by the drug companies. We are misinformed by device manufacturers, by the press. We actually believe that the treatment for existential suffering is pills and devices. And we have a constitutional right to be happy. And if I'm not happy, then you have to fix it. And if you're not going to fix it, I'll sue you. And this is the whole mind frame of the dialogue, the therapeutic dialogue that we have with patients who come in with that set of expectations. And so we know that there's a difference between pain as a byproduct of a disease and pain as a disease. Unfortunately, we have the same word, so let's use pain with a lowercase p and pain with a capital P. That's the difference. And if there's one thing that I want you to remember, is that there's a difference between pain with a lowercase p, that is the pain, what we call the normal pain, that everybody understands, that's treated easily, that all the doctors from all the specialties should and can treat. And then we have that pain with a capital P, that difficult one, that no one understands, that it is illogical, that doesn't respond to treatment the way it's supposed to. And that maybe then we have to send sooner rather than later to the pain specialist. So the 5 truisms that I'm trying to give to you is we have our inner world. We see what we see. And like I saw the dolphins and you did not, then this is what happens sometimes with patients. We feel pain with our brain. So yes, when we say it's all in your head, it is right. The pain experience is amplified, digested, and secreted in the brain. And the brain doesn't need a body to feel it. It can do it all on its own. And there are preliminary studies showing that the smarter the brain is, the more creative the brain is, the more imaginative the brain is, the more eloquent the brain is, the better it does. Pain is a complex phenomenon, and pain with a lowercase p is not like a capital P. So let's talk a little bit about pain out of the head. So what happens? How does pain start? So we won't talk about the demon theory, but we'll talk about what started in the Enlightenment age, where basically this is René Descartes, and he talked about the bell theory. And here's a fire, and we pull on a string, and that string goes all the way up to the brain, and you just pull it, and it makes a noise. And that noise is the pain. What you're hearing is the pain. And despite the fact of how simple it is, we haven't changed in the last 400 years. This is still how we see pain, and I'll show you slides of how complex and how interesting it is. But in essence, we still believe that if you tug on point A, like with fire or pressure or cold, that will activate something. That René Descartes thought it was the pineal gland, and today we say, no, it's not that, it's a whole bunch of other stuff. So when we start the pain, so the pain starts. This is the skin here, and this is the environment. And these are a whole bunch of receptors that are on the free nerve ending. And on them, these receptors, they allow us to interface with the environment. We need them. We need receptors that react to cold, hot, and touch. Children who have congenital analgesia, who have mutations in these receptors and don't feel pain, they die very soon. They break their bones, they burn themselves, they bite their tongue, they die. So we need the pain, we need that wall that allows us to interface with the world. And once that interfaces with the world, electricity emerges. And so, for example, this is when there's too much exposure. You look at that, that hurts. I agree, that hurts. And it goes up. It goes up, and it looks so much to what René Descartes drew. It goes up in these cables. Now, this is not true, but this is the way we conceptualize it. This is the way we explain it to patients. And if I would talk to you about energies going around, say, this is really weird. This is not how we think it works. And as it goes up towards the spinal cord, there is a first-order neuron and a second-order neuron, and there's a synapse between them. There's presynaptic receptors and postsynaptic receptors, all in the spinal cord. And so blocking the nerves stops the development of pain. This is a disease called CRPS, Complex Regional Pain Syndrome. It's after a minor trauma where you just barely had a sprain, and suddenly the hand or the leg it's not logical. Why would you have so much pain? Nothing's wrong. You take a picture of it, nothing's broken. You do other tests, everything's okay. To the point that you can't even touch it. That's what we call allodynia. That the touch feels like pain. Touch is supposed to feel like touch, not like pain. So things happen in our circuitry. So there's pain out of the head, and then there's pain in the head. And I think that this is what really is interesting. That despite the fact that we have spent so much energy in the pharmaceutical companies to try to understand different medications that would knock out different receptors in the periphery, and we can do injections and things, at the end of the day, what is really interesting is what happens in this tiny box. What's going on with the transparent brain? This is what we call Penfield's map. Penfield, in the end of the 19th century, drew a map on the cortex, basically representing different parts of the body. And as you can see, the feet, the hands, the face, the lips, the genitalia are highly represented in that cortex, which explains why we feel so well here and not so well in our back. Why there are certain areas that we can actually analyze and understand so much better. This is all the nuclei that have to do with appetite and sleep. Today we're understanding the relationship between these, I would say, basic life functions and pain. If, for example, you take women, 80-year-old women who have osteoarthritis who do not sleep because of their pain, you treat their sleep, the pain goes away. So there are changes in the circuitry that we're starting to understand, that pain doesn't happen in isolation, and we can explain the sadness and the loss of appetite and the loss of desire. So let's show a little bit of interesting areas to you. Now, traditionally we said, okay, where does the pain go? And we talked about the thalamus, and the thalamus goes up to that famous Penfield cortex, and that's what we call the sensorial component of pain. It says, where does the pain hurt? So if I bang my hand like this, I know it's in my right hand, and that area right here would light up. And then there are accessory cortices which say, I can just think about it or kind of redo this experience. I can almost feel it again, like just when you looked at that picture with the burned individual and you go, so there are secondary cortices, and there are emotional cortices, and cortices that have to do with self and with awareness and how we walk and how we carry ourselves. But I want to show you 3 circles. This is the first circle. This is the prefrontal cortex. The prefrontal cortex is the last of the cortexes to develop. There's a cortex that develops at the age of 22, 25. And we believe, by when we see patients who have diseased prefrontal cortices, it has to do with abstract and logical thinking. So if you have a teenager at home, and you want them to clean the room, do not explain to them that you have to clean the room because it's the right thing. Just give them $5 and they'll be fine. And I will show you slides where pain causes atrophy in the prefrontal cortex. And patients say, I'm not the same person I used to be. I changed. Pain made me stupid. I have patients who said that to me. And they said that to me because this is the other circle, and that is the amygdala. Amygdala in Latin means nut, and it looks like a nut. In women, it causes panic, severe anxiety. In men, it causes them rage. They become nuts. There's a reason for all this. And so if you have someone who has a amygdala hijacking, just wait. Don't bother them. It'll go after 2-3 minutes when all the neurotransmitters are done. Pain hijacks the limbic system. And pain also interferes with memory. That's the hippocampal area. Hippocampus takes care of short and long-term memory. And patients simply have difficulties in remembering things, in executing cognitive tasks. We see that every day, and they tell us this every day. This is what pain does to the brain. So, for example, this is a study done by Vanya Apkarian in Chicago, where he shows that there's a loss of gray matter in the prefrontal cortex. So patients, for example, if you have a task to pick a card, individuals without pain, they would take from this deck of cards, they would always win, and this deck of cards, they would always lose. And after 20 draws, you kind of understand that you just have to take from this deck. And patients who do not have this cortex continue even after 150 draws to be disappointed. And so there's actually a break between the somatosensor cortex and the emotional cortex. And so the reactions are illogical. So there's an explanation why sometimes we don't think, as people who do not feel pain, that the answers are the right ones. Now, can it be changed? The answer is yes. This is an example of a study that we did a couple of years back where we showed that patients who had pain, after we treated them, areas that were empty refilled. So we reversed that loss. And here's another example. You can see here that before treatment, here is one thalamus, and here's the other one that's pretty, dimmed. And after treatment, regained. And the same thing here, if you look at functional imaging and you see hurts, and this is the emotional part of it. Hurts, I don't like it. Hurts, I don't like it. Hurts, I don't like it. And here, after treatment, yeah, it still hurts, but we lost the aversive part of it. So yes, definitely there can be changes. This is called neuroplasticity. The brain changes all the time. This is why talk therapy is good. Some of you right now are very neuroplastic. You're listening like this and your brain is changing and you're going to go home and you understand things and this is good. And some of you are less plastic, more neurorigid and saying, when is this going to be done and why am I having this and so forth. And this is part of your brain. So how can we use this? For example, at Harborview, burn patients. This is Sam Sharar's lab. You're a burn patient and sitting in cold water, and instead of giving medication, and you know how painful the burn dressings can be, and instead of zonking them and putting them in anesthesia, you say, Mr. Ice, and listen to penguin music. I do that, by the way, every evening. I finish work, I go home, I draw a bath, put candles around the bath, and I listen to Barry White. That is how we recreate our reality. And we can see here, for example, the same areas with no virtual reality that are active after virtual reality are extinct. So the brain changes. Now, it's not only the person who has pain that the brain changes. This is a study done by Tanya Zinger, and she's done dozens of wonderful studies on what is called mirror neurons. Mirror neurons. When a patient talks to me about the pain in their hand, if I would have a functional image on my head, the same area in my brain would light. So it's not just that the patient's saying, I'm having pain and there's an area that lights up, is that I am listening to the patient. And she found out that the more you know the person, the stronger is the light. So obviously something terrible would happen to my wife, I would feel awful. As opposed to someone that maybe I don't know very much, and I can listen. Indifferent. It is a capacity that we can develop, and most of it is called the emotional contagion. Maybe you felt that once. Maybe you've looked at a picture and suddenly you felt part of it. Or maybe you've listened to music and suddenly you closed your eyes and you felt immersed in this. Those are the mirror neurons. So it's not only about the subjectivity, but it's what is the intersubjectivity. And this brings us back to context. When we walk inside the room, we're not kind of inert beings in there. We change the way we think. We change the context of things. And all this is via the mirror neurons. All the time you're looking, engaging, and listening, and looking at body language, and verbal cues, and nonverbal cues. The brain is active all the time. So what happens when I say to the patient, oh, you know, you have, by the way, instability? What does the patient see? Are they imagining, oh my God, I'm unstable. It's going to crack. I'm going to be in a wheelchair. And this is, for example, a patient that I saw that I asked them to ride a bike. I had back pain. I think that riding a bike is a good thing. So I said, ride a bike. And he didn't ride a bike. How dare he not ride a bike? A couple of weeks later said, I did not ride a bike. So I said, why didn't you ride a bike? And he said, because I have a herniated disc. Now, do I know, again, we're going back to the problem of the other mind, do I know what that means? Is his herniated disc my herniated disc? So I said, what's a hernia? He said, hernia is a tear. I said, fine. What's a disc? He said, a disc is that thingy in your back that allows you to walk. I said, okay, can you draw me a disc? So I said, sure, not a problem. Here, look at this. This is the back, and these are the legs, and these are the knees, and these are the ribs, and here is one disc, and here's the other disc. And one is already torn, so if I'm going to do like this, and I'm going to tear the other, and it's not good. Now, who is the one who doesn't get it? Is it him not knowing the objective truth that the disc is within the spinal column? Or is it me not understanding the inner representation, the inner world of what he's trying to describe to me? That is the true challenge. Let's talk a little bit about being careful of all these analysis of what we feel and what we think we feel. Talk a little bit about suffering. 150 years ago, there were a group of scientists in Germany who said if we measure exactly the skull, we can know things about people. These are the murderers, and these are the lovers, and these are the smart people, and they were called phrenologists. Looking at functional imaging like this is modern phrenology. Because we do an error that's called a mereological fallacy, or a mereological error. Mereology is, in philosophy, the science of the whole. And what we're doing is we're attributing the characteristics of a whole to a part. And all we're saying is, oh, the right side thinks, and the right side wants, and the left side does this, and that is not true. It is the person with the right side, the person with the left side, who wants and thinks and does that. And so we should not forget in our infatuation with technology and to reduce complex situations to something simple and elegant that we're talking about people. Pain requires the whole brain. It is an emergent property of a conscious brain. And unfortunately, we don't have time to talk about consciousness, and maybe another time we'll have this discussion of what is consciousness and what is the theory of the mind. But I'm sure that you can understand now that the only way to not have pain is not to have a brain. And this is difficult for us because we are Newtonians. We like to look at things linearly. 1 and 1 is 2. 1 and 1 is not 3. Causes come before effects, not after. But the brain and our behavior is complex. It's not linear. It's not simple. It's not predictable. It is much more complex to analyze. So if I take an average of all your pain scores and I say the average of your pain scores between 0 and 10 is 4.7, that is meaningless. Because some of you have 0, no pain, and some of you have a lot of pain. Last word on pain and suffering. It says here, Dr. Pain and Dr. Suffering. Do you want to see both doctors at the same time? So we like to think at the Center of Pain Relief that pain is mandatory. It's the suffering that's optional. It's almost, the response to pain. Pain assessment, you don't really need to know the person. You ask questions. Where does it hurt? How many times? How long did it take? What did it cause? 0 to 10. What's the quality? Sharping, shooting, We can do that. You don't need to know who is the person and what is their life story. And you can characterize the pain. Suffering, on the other hand, requires a narrative. Requires to understand who is the person that is in front of you and what are they trying to tell you. There's a cultural relevancy. Now, suffering is not only caused by pain. There are a whole bunch of other things that you can see here. And unfortunately, in pain, we use the language of suffering and vice versa. So it's very difficult to understand when pain means pain and pain means all of this. So those are the two things that I wished I learned in medical school. One is, what is the difference between pain as a byproduct of a disease and pain as a disease? And what is the difference between pain and suffering? And if I would know these two things, then I would be much more helpful to many people. The language of pain is always used for all those who suffer. So when we manage pain, that's fine. But when we want to take suffering and pain behaviors, we need to understand context and meaning. And by the way, doctors and healthcare providers are not the only people who are presented with suffering. My barber, for example, is one of them. And so the problem is that in the biopsychosocial model, yes, we talk about biology, yes, we talk about psychology, yes, we talk about social factors, but do we have time to incorporate context? Do we have time to understand meaning? Do we have time, or are we tone deaf to what the patient is trying to say to us? So really, I think that yes, now we're starting to understand that chronic pain is a disease within its own right, but it's really the suffering that's a challenge when we listen to the short life stories of the patients who come ephemerically before us. And so this is an example. The tolerance of pain is in direct proportion to the proximity of the mom. So on the left-hand side, you see this young child, I think that this may need stitches, and the child says, okay. As opposed to mommy who says to their child, I think you snagged a hangnail on your sweater, and you can see the drama that's going on. What patients say to my nurses, who say to my medical assistants, to say to my front desk, to say to my fellows, to my residents, are not the same things that they're telling to me. There are multiple stories that are going on. And that is what makes this so rich, but also so challenging. So when we write the next chapter in pain medicine, let's look at the future, and we'll finish here. If there's one thing I would ask you to remember, is to remember this. This is the mission statement. Look at the mission statement, and we know that today there are ways that we can predict pain. We can say you are at low, medium, or high risk to develop pain after injury or surgery. We can diagnose pain, do precision diagnosis when it's possible, and then do precision treatment when it's possible. But most importantly, we need to prevent pain from becoming a disability. Again, not the pain itself, but it's the disability, the functional impotence, the social isolation that comes with it that needs to be held. And that's a challenge, again, for cultural reasons, for societal reasons, when we believe that pain is a byproduct of a disease and should be fixed, and it can be fixed by pills and devices. So this is how the center looks. In Roosevelt, we had our ribbon cutting last fall, and in our entrance, we have the sign, so everybody can think, can ponder upon it while they're waiting to see their doctor. And so again, I want to remind you, pain is difficult, obviously for the patient, but also for the person who is sitting in front of the patient because of intersubjective reasons, because of the problem of the other mind. And it's tough for society because it really doesn't fit in what we think should work. And that's the paradigm shift. That what we concentrated was, what's the disease? What's the disease of that person? Oh, that's a heart attack case, and that's a leg case, and that's a head case, and that's a crazy case. Well, diseases. To translate that from event-specific to patient-specific and say which person has that disease. Remember what Voltaire said. We know nothing of the people in front of us. So again, Daddy works in a magical faraway land called academia. I don't want that. I want us to be relevant, open, and listening to our patients. Thank you very much. Okay. If there are any questions, there are microphones. Please speak clearly and loud, and we're on time, so that's fine. Yes, please.
Hi, I have a question, actually 2 questions. On your list of, excuse me, on your list of credentials, it says you are leading in the creation of the National Pain Registry and developing the Washington State Opiate Reform Initiative. Could you explain what both of those are?
Sure. So I'm sure that most of you know that the morbidity and mortality associated with prescription drugs has become a public health emergency in the state of Washington. Last year, more people died from OxyContin than from car accidents. That's how serious this is. And what we see every day at the Center for Pain Relief, we see anywhere between 80 to 100 patients. I would say 80% of them are people who are taking very high doses of opioids that are not helping. So the idea is to provide the physicians tools to evaluate their treatment, to tell them with screening tools that this is a good idea to give this medication, or maybe not a good idea to give this medication. To give them a follow-up tool and say, remember the patient you gave him this treatment? Not doing better, or actually doing very well. Good job. And so it's not about just teaching. Teaching is very important. But if you don't get a daily feedback on the quality of what you're doing, it's very difficult to change things. Yes, sir.
Yeah, one of my friends is suffering from chronic pain and makes it hard for her to walk. And she is, in fact, being treated at the Roosevelt Clinic. And she mentioned one doctor is telling her to take an ibuprofen, is that the name of it, one in the morning and one in the evening. And another doctor she mentioned is giving her cortisone, but that each of those, the cortisone injections and the ibuprofen tablets can cause liver or kidney damage. So when do we know whether the kidney and liver damage is worth being relieved the suffering of the pain?
So the question was about treatment and how do we balance between 2 evils. One is the pain and the other one are the side effects of medications. And this is in fact what we're doing every day. And this is why we have a large group of professionals. We do not practice alone. We once did a fun calculation saying that we have over 350 years of experience. A lot of really senior physicians there under one roof, and we meet regularly and we discuss patients and we try to balance, and many times it's between 2 evils. It's not just one good solution, but you're right, it is very, very difficult.
You alluded to a smart mind. Does that mean that does a smart mind have less pain or more pain, or is it just that it can create new and interesting symptoms?
Well, I think it's an interesting question. So do smart minds, or do smart people with people with smart minds, do they have a tendency to have more pain or less pain, or can cope with pain or not? I would say that it's a combination of both. I would say, and there's starting to be interesting studies coming out that sensitive people are sensitive. It's that, we use the right language. When patients say, oh, my nerves are all itchy, or I'm sad. When you are very aware to your surroundings, that can cause pain and suffering. You blush, you don't feel, you feel awkward, you feel aware, So consciousness, this phenomenal awareness, is something that might predispose you to experience certain perceptions that other people that are just, bulldozing through life are not aware of. But that neuroplasticity is also the key to learn. And that key to learn is the key to adapt. And to say, this is not a good behavior. This is not a good strategy. Sitting around and moping is not a good thing. And maybe I need to take care of myself, because if I won't take care of myself, nobody will take care of myself.
So you can make choices and you can respond.
Exactly. There are structural differences in hypnosis. If now we would ask everybody to close your eyes and you would go like this, and I would say, okay, imagine one hand is heavy and the other one is light. Some of you would be like this. And some of you would say, open your eyes and something. I'm proud, I'm like this. And that we know that there are differences in the brain structure, that the connections between the two hemispheres through what we call the corpus callosum is much thicker in people who are able to be hypnotized. So I think that it's fascinating to see all these things, but always put them in perspective. Time for 2 more questions. Yes?
Okay. I have one more question.
Sure.
Since there are concerns about the use of opiates, not only from a perspective from the physicians who are prescribing them and being prosecuted for overprescribing, but also from the perspective of their use and abuse. What is your stance on the use of medical marijuana for the use of pain management, for chronic pain, for, say, cancer patients or AIDS? I know it's a
So the question is a very,
topic.
it's a simple question with a long answer that I will make it short about medical marijuana, since now we added the name medical to it, so now it's all right. So I just want you to understand what marijuana does, okay? Marijuana is an agonist of a receptor that is called the cannabinoid receptors, CB receptors, CB1 and 2, that most of them are in the hippocampus for memory. And when you take animals and you take away the CB receptors, they're happy campers. You put them in a box, they go to one side, they go where the food is, you zap them, they'll still go back and forth. You take a normal rat once, twice, they won't go a third time. So cannabis is good not to retain aversive memories. It's great. Life suddenly looks good, But the problem is that learning about aversive memories is one of our strongest tools to learn about life. That is why we don't stick our head in the fire again and again and again, because it's not a good idea. So again, the question is, for what context? Perhaps someone who's at the end of life, who has a low appetite, and thinking about the imminent departure from this world, maybe giving them a medication that would not allow them to retain this aversive memory, maybe that's a good strategy. Should we do this in everybody? I'll let you decide. Last question?
Many times we use 2 different words. One is mind and one is brain. And I'm very curious about this, one a subset of the other, or when we talk of this, what does the medical community mean about that in general?
So that's really a very good question. Inter-exchanging between brain and mind, and is that correct? So the short answer, no, it's incorrect. It's incorrect to substitute it. I'm doing this for sakes of convenience, because we will need to educate ourselves in the theory of the mind for more than a couple of minutes to try to understand what mind is. The way I explain it is that mind, I don't like to use the word mind, because it's something that say you have. So you have, you own, you lost your mind, you got your mind, too much mind, you're mindful. It's not something that you own or you lose. I like to think of it as a capacity. Let's call it mentality. The capacity to live life. Capacity to experience life as is. And if we do that, then brains are different. And each brain has that capacity. And that is the relationship. But we use it interchangeably because not many of us actually understand or are familiar with the concepts of what mind is. But thank you, it's a very good question. Okay, thank you very much, and good evening.